So it's an enormous pleasure and honor to be here to talk about this study. And I'm going to start by saying a couple things at the front end. First of all, this is the most comprehensive, most thorough analysis of the literature and response to patient voices that has ever been published on this particular topic. It provides a firm foundation, both for making the diagnosis and more important and equally important for future action. So I just want to start out with that. Okay. This report was commissioned in response to the Chronic Fatigue Syndrome Advisory Committee to promptly convene at least one stakeholders workshop in consultation with CFSAC members to reach a consensus for a case definition. Now, I want to be really clear here that this is what CFSAC wanted. What our funders actually did was something somewhat different, and I realize that that's a bit source of some contention, but they contracted with the Institute of Medicine to develop evidence-based diagnostic criteria for this disorder to address the needs of health providers, patients, and caregivers, considering the various existing definitions and other diagnostic issues. We were also asked to consider the desirability of new terminology for this disorder, and we were asked to develop an outreach strategy to disseminate the definition and a plan for updating the new criteria. Now, here I want to make a comment about IOM studies. The Institute of Medicine convened a group of very diverse people, including patients, including caregivers for patients, one of whom is in the room here, Ron Davis, including experts in this disorder, including experts in a number of other disorders, and experts in research design. So it is this diverse group of people who, after extensive discussion, after extensive review of the literature, developed this research definition. So this is a multifactorial, multidisciplinary process. The other thing to say about the Institute of Medicine process is that we do the work that we have been asked to do. We do not go beyond the work that we have been asked to do. This is something that is important in Institute of Medicine research. And so I just want to identify that the scope of our task is defined by the statement of task. We did a lot of things. We had 5 different meetings where we met. We had 2 public sessions where we had testimony from patients and experts. We reviewed almost 1,000 public comments, which we did carefully and systematically to ensure that we were adequately taking care, addressing the issues of patients and advocates. We had input from the CDC multi-site clinical study. We had been told to look at the P2P process. We were unable to get that data. We also had consultants who talked about communications and statisticians who summarized, who looked at some of the more complex statistical analyses that were undertaken. And we did a comprehensive literature review. Look at these dates, January 1, 1950 through May 30, 2014. This is a lot of time. We developed inclusion criteria, looking not only at articles that focused on the diagnosis, but also looking at the quality of the research that went into that. We started with almost 10,000 articles. After a lot of analysis, we looked more closely at almost 3,000 articles. We ultimately found a fairly small number that actually met the criteria for our work. We also looked at almost 1,300 articles that were submitted by people submitting comments to us. So, you know, a tremendous amount of work looking at lots and lots and lots of articles and data. Our key messages are this. One is that this is a serious, chronic, complex, multi-system disease that can profoundly limit the health and life activities of these patients. This is a serious disorder. And that doing a thorough history, physical exam, and targeted workup are necessary to determine a differential diagnosis and often sufficient for the diagnosis of this disorder. So our first recommendation is that if a physician goes through the diagnosis, and I'm going to talk about the criteria in just a minute, but if people meet the criteria for this disorder, they ought to be given the diagnosis and not another diagnosis. They need to be given this diagnosis, and that there needs to be a change in the ICD-10 to reflect this diagnosis. I realize that this is something for the actions of others to take care of, but one that's actually very important in this setting. So here are our criteria. I know that all of you probably know this, but just to rehearse them really quickly, there needs to be substantial fatigue, and not just feeling tired, but fatigue that is chronic, severe, and that gets in the way of your ability to do your activities of daily living, and that even if you can push through it, that nonetheless it leaves you exhausted. So a major issue here. The post-exertional malaise, which is the inability to replicate exercise on more than one occasion, unrefreshing sleep, which is something that virtually every patient with this disorder has, and then at least one or two of the following manifestations: either cognitive impairment, which is the inability to think well. We heard from this very frequently, or orthostatic intolerance, the inability to stand up or sit up for a long time without becoming faint or dizzy-headed. These criteria we picked because they are virtually always present, and they are virtually always present in combination. And so that's how they became the core criteria. That is not to say that there aren't many, many other symptoms that people with this disorder have. And this is not an exclusive list. This is just a list of some of the many domains in which patients with this disorder can have symptoms. And so it would not be a mistake to say that this disease is protean in its manifestations, but it has core symptoms that need to be present in order to make the diagnosis. I want to give a reflection here. These slides, if it looks like this, it means that it's my thoughts. The other ones are IOM slides. So I'm clearly signaling when I'm talking as an independent person here. Reading this literature, it is really clear what this disorder is. Listening to patients, it is really clear what this disorder is. It jumps off the page. And so this was, although, we had a lot of discussion, it was not hard to come to consensus about what the core symptoms are, because it is just, you can't miss it. So I'm just reflecting that. Treating the symptoms. We did have a 6-month threshold for making that diagnosis. We do recognize that people who have this disorder have disorder for the preceding 6 months. And what that means is that people who have symptoms need to be treated, whether they've had them for 6 months or not. They may not qualify for having the diagnosis yet, but that doesn't mean that they don't deserve appropriate care and treatment. Our second recommendation is that the Department of Health and Human Services should develop a toolkit for screening and diagnosing patients. It is the view of the committee that probably somewhere between 80 and 90% of patients with this disorder are not diagnosed. They must be diagnosed. They must get diagnosed, and they must get into treatment. And that part of what needs to happen is develop the tools to make that happen. And that they need to be available for every clinical setting where these patients are seen, which is everywhere. primary care, everywhere. It is our hope that these tools will educate clinicians and other providers. We want them to understand that this is a serious disorder. We want them to understand how to diagnose it. We hope that no one ever hears again the statement, is this disorder really real? It's real. So let's get over that one and get on the business of making the diagnosis. The Institute of Medicine has already published a clinician guide that's available on our website, and as well as summary materials, as well as the whole report, which you can download for free as a PDF or which you can buy. But this is available to everyone, but the PDF is available to everyone for free. There is no excuse not to learn what this is. And then I'm going to give a shout out to a YouTube that was created by Dr. Cindy Bateman, who was on our committee, who's done a wonderful YouTube discussion of the report and how to make the diagnosis. It takes a while to watch it. It's over an hour long, but boy, it's an awesome discussion. So I just want to alert you to that too. And that, by the way, was a personal recommendation. This is not from the IOM. This is just from me, okay? My third recommendation, our third recommendation was that these criteria need to be revisited in no more than 5 years. We recognize that our criteria now represent the state of the science at a moment in time. It is our fervent hope that the science is going to move forward. It is our fervent hope that soon we will know more about what causes this disease. We will know more about subtypes of this disease. We will know more about how to treat this disease. It is either hubris or stupidity to say that a statement at one point in time is the vision of the truth that is going to last forever. But particularly in this disorder, it is our fervent hope that this community will know more soon. And to that end, there needs to be another literature review, and there needs to be another assessment of the diagnostic criteria, and that it needs to undergo the same kind of rigorous process that was undertaken here. And we also recognized, because we were asked what we thought about the current name, we addressed that issue. And we thought that chronic fatigue syndrome has not served these patients well. I can't tell you how many comments we had where people said that. We also thought that myalgic encephalomyelitis, as much as people liked it, didn't work because it doesn't describe what this disorder is. There is a long history in medicine of coming up with names based on symptoms when you're not clear what the etiology is, which is what we think the state of the science is. This is the name that we proposed, but we came up with this because that's what we were asked to do. So, I mean, I'm just putting that out there. We also did address the issue of pediatrics. Turns out this disorder is common in kids, and it comes at a terrible time because they're mostly teenagers, and teenagers who miss out on being teenagers have an almost irreparable loss. They miss out on school, they miss on all the developmental tasks that are going on with teenagers. And so we wanted to call that out. We found that there was sufficient evidence that orthostatic intolerance and autonomic dysfunction were major factors in them, that they do have evidence of neurocognitive disorders. They have a very high prevalence of the other symptoms. And importantly, this is a group in which it is very clear that Epstein-Barr virus, which causes infectious mononucleosis, appears to be a major trigger in these young people. We also identified a number of comorbidities with these disorders. It is crazy to think that if you have one diagnosis that you can't have another one. I mean, most adults they may have diabetes and hypertension and chronic renal failure and many other disorders like that. And to say that because they have diabetes, they can't have all the other things is really crazy. So we want to identify that people can have other things. And that for that reason, we did not identify exclusionary criteria because we think it's possible to have more than one thing. If you have the core symptoms of this disorder, you have it, you can have other things too. So I just want to put that up there as well. Obviously, I've already talked about areas that need further study, including etiology, pathophysiology, and effective treatment, and that really more needs to be learned. So I want to have some thoughts going forward. It is my sincere hope, and indeed I think the sincere hope of everybody on the committee, that people are going to use this report to say, this is a serious, complex illness. It makes people sick, and it's really bad. And we need to learn more about it. We need to identify it. We need to treat it. We need to develop more effective treatments. And I think the fact that this study was funded by Health and Human Services, AHRQ, the CDC, the Food and Drug Administration, NIH, the Office of Women's Health, and the Social Security Administration suggests to you that there are a lot of branches of the federal government that are interested in these questions. So go talk to them. It's really important. And it's really time to fund more research into this disease's causes, defining subtypes, and effective treatments. I can't emphasize that enough. Focus on what the main message of the report is. This is a disease. We know how to diagnose it. We need to learn more about it. That's the main message. And people getting distracted by other things are missing an amazing opportunity that they need to grasp. And this will require stronger advocacy in and outside the government. So this is the cover, and we opened a door. There is a light at the end of the tunnel. The challenge now is to go through that door. Thank you very much.